removed the word challenging because some of these cases they might not be challenging for you, but challenging for others. We'll start with our first case, a 66-year-old female, known case of hypertension, dyslipidemia, and old stroke, who presented with jaundice, dry mouth, and B symptoms. She was found to have hepatosplenomegaly, enlarged salivary glands, cholestasis, and lymphocytosis. Her CBC was significant for leukocytosis with predominantly lymphocytes. She had a normal hemoglobin and platelet counts. This is her peripheral blood. And as you can see, small to intermediate sized lymphocytes with dark basophilic cytoplasm, irregular nuclei, and clumped chromatin. She had flower-like, cleaved, and cerebriform nuclei. You can see over here. Over here you have the more cerebriform. But the predominant ones were the flower cells. Bone marrow aspirate showed similar morphology with infiltration by lymphocytes. You can see over here in the yellow arrow. This is her flow cytometry. It showed a T cell population expressing CD3, CD5, predominantly CD4, CD2 positive with partial loss of CD7. It was also expressing CD25, CD27, and majority were TCR alpha beta. So final diagnosis was bone marrow infiltration by CD4 positive T cell lymphoma. She did not have any skin rash. It's most suggestive of adult T-cell leukemia lymphoma. We ruled out Sézary. It was helpful that she didn't have a skin rash. And we asked to correlate with HTLV1 serology and PCR. So this is a Saudi citizen. So when the clinicians heard about this, they were surprised. As you know, this disease is seen majority in Japan and the Caribbean. And why would we have one patient with this virus? So her test came back positive for antibody as well as DNA PCR for HTLV1. EBV and CMV were negative. She had high LDH calcium levels. Autoimmune workup was negative. Going back to the pathogenesis of adult T-cell leukemia lymphoma, the infection is usually by vertical transmission from the mother to infant or during breastfeeding. During that time, the first hit happens. The second step in the sequence is proliferation and high proviral load. After that, there will be natural selection, so only the clones with the proliferative advantage will expand, and this will eventually impair the cytotoxic T-cell response. By the age of 30s to 70s, you'll develop a clonal tumor that is positive for CD3, 4, as well as chemokine receptor 4, and negative for CD26. So our patient actually came to us in the acute phase, which is fatal. So unfortunately, she passed away. She couldn't tolerate chemotherapy because of her very elevated liver enzymes. There are also some targeted therapies directed towards CCR4, but it wasn't available at our hospital. As you know, adult T-cell leukemia lymphoma is a T-cell marker that expresses CD2, 3, and 5, and usually lacks CD7. Most of them are CD4 positive, but you can have CD8 or double positive or double negative subtypes. CD25 is expressed in most cases, and CD30 might be variable, but it's almost always negative for cytotoxic molecules. As I said, they frequently express chemokine receptor 4, which could be a therapeutic target. Some studies showed that downregulation of CD7 and upregulation of chemokine receptor 7 and CAD-M1 are more frequently observed in aggressive ATLL compared to indolent ATLL. So the differential diagnosis, of course, you have to take the entire clinical presentation. And see if she has, the skin rash. But Sézary syndrome, if it had a lot of nucleoli, you will think about TPLL. If it was mainly lymphadenopathy, you'll think about peripheral T-cell lymphoma, T follicular helper lymphoma, angioneoplastic, and systemic ALCL. The diagnosis is confirmed by viral serology or detection of DNA. So we're going back to the incidence of HTLV1 and 2 in Saudi Arabia. This is a study by our own Dr. Al-Bahrani. The overall incidence was 0.002%, and they were debating whether to cancel the screening of donors because of the low prevalence. So going back to our patient, she's a Saudi citizen, but she was actually born in Kurdistan in Iraq. So this is actually an area known to be endemic for HTLV1. So northern Iraq and Iran are known to have HTLV1, so that explained why she had it. Case number 2, a 38-year-old Saudi male who presented with fatigue, abdominal distension, with massive splenomegaly and pancytopenia. As you can see, he's showing leukopenia, anemia, low platelet count. The cells were predominantly lymphocytes, with atypical lymphocytes accounting to 14%. His peripheral blood, as you can see, showed marked neutropenia and monocytopenia, 12% atypical lymphocytes, some showing cytoplasmic projections. His bone marrow was surprisingly very good, with multiple cellular particles. It wasn't a dry tap. And you can see the lymphocyte had pale cytoplasm. A lot of them had circumferential cytoplasmic projections. Some of them had indented nuclei, and occasionally prominent nucleoli. There was reduced trilineage hematopoiesis. This is the flow, and as you can see, we have a B-cell population that shows bright CD20 expression. You also have CD10 positivity, CD200, negative for 23 and 43, and negative for 79B. It was also positive for cytoplasmic lambda, and negative for CD5 and CD38. So the morphology was pointing towards something, but now we have CD10 positivity. We went ahead and did the additional markers. So CD25, 95, 103, and 11C were all positive. Bone marrow morphology is classical fried egg appearance. So this is a hairy cell leukemia with CD10 expression. It has been reported rarely. It doesn't have any significance as for now. The differential diagnosis is, of course, splenic B-cell lymphomas with prominent nucleoli. So I know that Dr. Khalid explained in detail, but in the new WHO, they wanted to steer away from calling hairy cell leukemia variant and B prolymphocytic leukemias. They lumped them all into this category, splenic B-cell leukemia lymphoma with prominent nucleoli. If you exclude hairy cell, if you exclude mantle cell, and if you exclude prolymphocytic progression of CLL, you're left with this category. As you can see, a lot of these splenic lymphomas have overlapping features. We would like to see the classical features that Dr. Khalid showed to us, but in reality, a lot of this morphology overlaps. A lot of them will have projections. If we're lucky, we'll see polarized, but a lot of them might have circumferential projections. So morphology alone is not, it's not diagnostic, but you have to make sure that the cells are not completely showing prominent nucleoli. To see the difference between splenic B-cell lymphoma with prominent nucleoli and hairy cell, you see the hairy cell markers are there, as well as annexin-1, which is probably most specific. Going down to the mutations, you'll see less than 10% BRAF in this category, which is the splenic B-cell lymphoma with prominent nucleoli. So there is some overlap, but always look at the annexin-1 and the expression by flow cytometry of these classical markers. So what we need to diagnose a hairy cell leukemia is characteristic morphology in the peripheral blood or in the bone marrow, strong positivity for CD20 and annexin-1A, or co-expression of CD20, 11C, 103, 25. If you have this, you don't need to do the molecular for BRAF. And you can see here there is significant overlap by features and immunophenotype. But as I said, you have to rule out CLL, mantle, and hairy cell before you diagnose this entity. Case number 3, 14-year-old female, previously healthy, no significant medical issues, who presented with fever, generalized lymphadenopathy, hepatosplenomegaly, and blastoid cells in the peripheral blood. She had low hemoglobin of 7.8. She had a platelet count of 30, low, and atypical lymphocytes, 17%. This is her bone marrow aspirate. On the left side, you see infiltration by these 18% blastoid cells. They're mediate to large, hyperchromatic, with irregular nuclei, prominent nucleoli, and vacuolated cytoplasm. So they kind of look like lymphoma cells. On the right panel, you'll see more proliferation of granulocytic and monocytic cells. So there is a left shift in monocytes and granulocytes, but no significant increase in blasts. But as you can see, the morphology was overlapping. So is it a leukemia or is it a lymphoma? Flow was not that great because, as you can see, a lot of these cells were monocytic cells, sorry. So there was a population that was high on side scatter and the lymphocyte gate. This population was CD3 positive, as well as CD8 positive, with loss of CD5 and loss of CD7, without expression of CD56. So you have a predominantly CD8 positive T lymphocytes with aberrant loss of expression. This is to summarize: 15% positive for CD3, 2, 8 bright, and negative for 4, 5, and 7. So suggestive of a clonal population, clonal T-cell lymphoma population. Leukemia screen showed no blasts. Bone marrow showed infiltration by these hyperchromatic cells, look like lymphoma cells, large lymphoma cells, as well as lots of hemophagocytosis. This is the lymph node biopsy, similar morphology as the bone marrow. Immunohistochemistry, it's positive for CD3, negative for 20. As you can see, because of the increased monocytic precursor, you'll have a lot of CD4. But if you compare the CD8, all the cells are positive for CD8. So this is definitely a CD8 T-cell lymphoma. EBV positive, CD30, and ALK negative. So this is EBV positive T-cell lymphoproliferative disorder, also known as systemic EBV positive T-cell lymphoma of childhood. EBV DNA detected 46 million. This is the highest EBV copies I've seen in my life. And she had a fulminant course, of course, and she passed away. So she has fever, hepatosplenomegaly, lymphadenopathy, anemia, thrombocytopenia, low fibrinogen, high LDH, high ferritin, 50,000, going with hemophagocytosis, HLH. So she had both lymphoma and HLH. Systemic EBV positive T-cell lymphoma of childhood is a clonal proliferation of EBV infected cytotoxic T cells that occurs in immunocompetent children and young adults, and it's associated with HLH, multi-organ involvement, and rapidly fatal course. This is the spectrum of EBV positive T-cell natural killer lymphoproliferative disorders, and the main things here are EBV-associated HLH, chronic active EBV infection, which can progress to systemic EBV positive T-cell lymphoma. The neoplastic cells are usually CD2 positive, 3 positive, 56 negative, and TIA positive with aberrant loss of CD5 and CD7. If it was an acute primary EBV infection, most of the cells will be CD8 positive, but if it was a progression from chronic active EBV disease, it will be CD4 positive. Rare cases may be double positive, and EBER is always positive. The differential diagnosis, as you may know, in acute EBV infections, you might have clonality by T-cell rearrangement, and you might have loss of CD5 and CD7. So these features are overlapping between both. If you find clonal cytogenetic abnormalities, this will point you towards this entity, the systemic EBV infection or T-cell lymphoma of childhood. And for our bone marrow, our bone marrow showed a complex hyperdiploid karyotype, including several markers and ring chromosomes, and this confirmed our diagnosis. Case 4, 65 years old female with history of chronic ITP, presented with left arm pain, which prompted the physician to order a CT scan. CT scan showed multiple lytic lesions. SPEP shows an M protein spike in the beta gamma region, 47 grams, elevated IgA and high kappa lambda ratio. Immunofixation consisted with IgA kappa. Her CBC was significant for anemia, and platelet count that was low. Lymphocytes were 69%. So she has relative or absolute lymphocytosis. Her peripheral blood showed rouleau formation and lymphocytosis with plasmacytoid lymphs, no circulating plasma cells. Her bone aspirate was cellular, again showed a similar morphology. However, you start seeing these very small lymphocytes, almost resembling a plasmacytoid lymphocyte, but they're actually lymphoid plasma cells. I know I'm confusing you right now, but they are very small plasma cells. There are no significant increase in lymphocytes. Flow cytometry showed in the plasma cell gate, which was CD45 negative, showed 10% population that is positive for CD45 dim to negative, 38, 138, 20, 81, 27, cytoplasmic kappa and beta-2 microglobulin. It was also negative for 19, 117, 28, and 56. So we have a plasma cell population that is aberrantly expressing CD20. So this is plasma cell myeloma, lymphoplasmacytic variant. It was mentioned in the previous WHO. I see no mention of it right now. It has, there was infiltration by 80 to 90% by kappa light chain restricted plasma cells. And this entity is known to be cyclin D1 positive by immunohistochemistry, but is not necessarily show the translocation. It's reported to have a better prognosis than other subtypes of myeloma, but more studies need to be conducted. Our differential diagnosis in such cases is lymphoplasmacytic lymphoma. Even though it's an IgA, as you may know, there are reported non-IgM lymphoplasmacytic lymphomas. It accounts for about 5% of LPLs, and they could also be non-secretory. It typically involves the bone marrow, just in our case, less frequently lymph node and spleen, and usually expresses B-cell markers. So you'll find CD19, CD20, 22, 79, and 38, as well as light chain restriction. The plasma cells may predominate post-treatment, and you have to look for MYD88 or CXCR for somatic mutation. And we have seen cases where the features are so overlapping that the molecular will do the diagnosis. Case 5, 43-year-old male referred with left adrenal mass for workup. He underwent a left laparoscopic adrenalectomy. As you can see, this mass was mostly composed of sheets of plasma cells with plasmaplastic and anaplastic features. CD20 negative, CD138 positive, lambda restricted by ISH. EBV is diffusely positive. Other findings, cyclin D1, 30%, KI, 30%, so it did not show a very high proliferative index. Negative for PAX5, 56, c-KIT, HHV8, CD30, and ALK. This patient was immunocompetent, no immunodeficiency known. So this was most compatible with extramedullary EBV positive plasmacytoma, also known as EPIC. He did not have any lymphadenopathy or bone lytic lesion detected on CT scan. He did have a small M protein by SPEP 1.8, so below the cutoff for myeloma. Bone marrow evaluation repeated multiple times is negative for plasma cell dyscrasia, and he had EBV DNA detected in the peripheral blood at around 128,000 copies. So this patient actually had a very progressive course. He had repeated plasmacytomas coming out in the abdomen and different parts of the body, required aggressive chemotherapy and even an auto stem cell transplant. So it wasn't a smooth course, even though it's an isolated plasmacytoma. So in general, plasmacytomas are almost always negative for EBV. You can see rare EBV positive or epics, as we call them. They involve the nasal cavity, head and neck, and GI, which has significant overlap with plasmablastic lymphoma. Histologic and immunophenotypic features are similar to other plasmacytomas, except EPIC can contain CD8 positive T cells. Usually it's extramedullary, but there are rare reports of medullary involvement. So plasmablastic lymphoma is the main differential. It arises in patients with immunodeficiency or dysregulation. However, in the elderly, some people claim they have immunosenescence, and that might make them immunodeficient. So they might have plasmablastic lymphoma, so it's not just restricted to HIV. They express plasma cell antigen, negative for 20, PAX5, ALK, and HHV8, and positive for EBV in 60%. Compared to EPIC, they have a very high Ki67 proliferation index, and more commonly, you will find MYC rearrangements. But there are significant overlap between plasmablastic lymphoma and plasmacytoma or myeloma in general. Always look for light chain restriction and look for monoclonal proteins in the serum for a diagnosis of plasmacytoma or myeloma. This is all I have for today. Maybe I went too fast for the time. Thank you.